Hey guys, I'm going to get you to actually work your way through the muscles, the actions of different muscles from the lower limb, which is a continuation of what we were looking at the other day in class. We finished off looking at vastus medialis, so we looked at the quadriceps group, and then now we move on to the other muscles of the thigh. So biceps femoris. So the origin here is the ischial tuberosity, right? So that's the posterior inferior aspect of the pelvis, often referred to as the sit bones or seat bones. And the thing to notice about biceps fem, and the reason it's called biceps is because there's two heads distally, is that it crosses both the hip joint and also the knee joint. As a result, then, and again, this is a posterior view, it'll extend the hip and, depending on the position of the hip, can cause flexion and flexes and externally rotates the knee. Externally rotates the knee. So this is fibula, this is tibia. And so contraction will rotate the knee externally. All right, moving on. Semimembranosus is, again, this is a posterior view, and we're looking at the, it actually has an insertion into a muscle known as the popliteal, I apologise. It does. The origin is also the ischial tuberosity. The origin is the ischial tuberosity, so this is a posterior view, and also crosses the hip and also crosses the knee. So it's going to have action at both. And so the origin is the ischial tuberosity, and it goes into a range of different structures, but just think about it going into the tibia, right? So this is fibula here, tibia here. So it inserts into the tibia. Now this is medial, right? So this one, right? So that biceps femoris is lateral, whereas semimembranosus is medial, isn't it? So it'll extend the hip as well, right? So extend the hip joint, and it will flex and internally rotate the knee, whereas biceps femoris will externally rotate the knee. And that's really because of the position, isn't it? So this is inserting into fibula, and this is inserting into the tibia. So medial side rotates it medially. Semitendinosus, again from the ischial tuberosity, and again medial, and again crosses the knee and inserts into the tibia. So as a result, it's going to extend the hip, which they all will from that posterior position on the pelvis, flex and internally rotate the knee. So flex the knee and internally rotate the knee as well. All right. I just want to make mention of this. This is the piriformis muscle. We'll look at here's piriformis here. From the anterior aspect of the sacrum into the greater trochanter. Now, as you can see from there, this is posterior view, obviously. And so when it contracts, it's going to externally rotate the femur, isn't it? It's going to externally rotate the femur and abduct the femur as well when it's flexed. But the reason I've also flagged this is because of the presence of obturator internus. Now, obturator I'll flick over to this one. I should have done that before, but obturator internus covers the obturator foramen on the internal aspect of the obturator foramen, and then it moves out onto the greater trochanter. The reason I've included these both is because in between both of these muscles runs the sciatic nerve. I'll say it again, in between both of these muscles runs the sciatic nerve. If the piriformis becomes overly constricted or tight, then what it can do is push on the sciatic nerve against the obturator internus muscle and create symptomatology not dissimilar to a disc prolapse in the low back. If a disc prolapses in the low back, it can put pressure on the sciatic nerve here. But by the same token, if the piriformis muscle is excessively tight, it can compress the sciatic nerve here. So sciatic nerve compression here for a disc pathology, sciatic nerve compression here for piriformis syndrome. Both create the same symptomatology. So from a clinical perspective, it's important that if somebody is complaining, for example, about low back and or pelvic pain, and they're reporting symptomatology which is reflective of sciatic nerve compression, you do need to separate out the disc pathology, from the muscle involvement as well. All right, so there's obturator internus there, so it's a posterior surface of the obturator membrane. Now remember, this is the obturator foramen, this is a posterior view, and so the obturator internus actually inserts to the internal aspect of the obturator foramen and then goes out to the greater trochanter. As a result then, you can see when it contracts, it's going to externally rotate the femur, and it's also going to abduct the femur as well. Obturator externus is on the external surface of the obturator foramen, or anterior surface, same thing, and it also goes into the greater trochanter, but at an area known as the trochanteric fossa. Now, it's still posterior to the axis of rotation for the hip, and as a result, when it contracts, it's going to externally rotate that hip, but it's also going to abduct the femur as well. Superior gemellus from the ischial spine. Now, the ischial spine is a projection on the posterior aspect of the pelvis, the ischial spine, and it goes out into the greater trochanter medial aspect. So same deal, because it's behind the axis of rotation for the hip, then it will externally rotate the hip and abduct the hip as well. Inferior gemellus, so look at the position of superior gemellus. Now that's the inferior gemellus here, upper part of the ischial tuberosity. So again, that's that posterior projection on the pelvis itself, the ischial tuberosity, and it's out to the greater trochanter as well. But again, posterior to the axis of rotation for the hip, so externally rotates the hip and abducts the hip when it's flexed. The quadratus femoris, ischial tuberosity as well, into the greater trochanter at the intertrochanteric crest. As a result, external hip rotation as well. Glute max, it's got a number of origin points, right? So from the iliac crest down through the sacrum. So sacrum, coccyx, gluteal surface of the ilium. So I would remember essentially the ilium and also the sacrum, and it goes out to the ITB, the iliotibial band, which is this band of fascia on the lateral aspect of the thigh. So it will extend the thigh and externally rotate the thigh as well. It will also abduct the thigh, and the inferior portion, lower down, will actually adduct the thigh. Glute med, so that's obviously glute max, both deep but superior and anterior to glute max is glute med. So again, from the ilium, right, from the ilium out to the greater trochanter, obviously abduction of the hip. And internal rotation. And the reason it's internal rotation is because the attachment point actually is anterior to the axis of rotation for the hip, and as a result, internally rotates the hip. And then finally, glute min. So glute max, glute med, and then deep to both of them is glute minimus from the gluteal surface of the ilium into the greater trochanter as well. Abduction of the hip, and again, it sits anterior to the axis of rotation for the hip, and as a result, it internally rotates the hip. Tensor fascia lata is a muscle that starts from the ASIS, the anterior superior iliac spine, ASIS, and runs down into the ITB, the iliotibial band. As a result, when it contracts the iliotibial band, and the iliotibial band, when it's contracted, results in the abduction of the hip. Medially rotates, so internally rotates the hip and flexes the thigh, the hip, and also helps to extend the knee. Femoral triangle is in the anterior aspect of the thigh, and so the borders of the femoral triangle include what is known as the inguinal ligament. Now, the inguinal ligament runs from the lateral aspect of the pelvis down to the pubic crest, right? So the ligament runs from the lateral aspect of the pelvis anteriorly down to the pubic crest. Medially, we've got the adductor longus, and laterally sartorius, that make up what is referred to as the femoral triangle. And located inside the femoral triangle is the femoral nerve, the femoral artery, the femoral vein. As a result, then, all of those structures are susceptible to impingement by compression of either, less so the ligament, but compression of sartorius or adductor longus as well. So this is it has clinical relevance as a result. Okay, I might skip that, but I'll allow you to go and have a look at that yourself and complete those activities. All right, on a sheet of paper provided with your name on it, explain the significance of the location of the sciatic nerve and its relationship with a pain that can mimic disc pathology. So in your answer, explain the location of the nerve relationship to the two muscles and name the two muscles, the mechanism that creates sciatic symptomatology, and a test that you may be able to undertake to determine whether the mechanism causing the symptoms is muscular or not. Now, obviously, I'm talking about this scenario, right? So it's impingement of the sciatic nerve where it runs between piriformis and obturator internus, right? So that's what we're actually looking at. And just moving back to this one here. So they're the two muscles. The mechanism is tightening of or constriction of piriformis, compressing the sciatic nerve. Anything that lengthens piriformis, like hip internal rotation, will further tighten piriformis and put pressure on the sciatic nerve, creating piriformis symptomatology. Sciatic symptomatology or sciatic compression symptomatology. As a result, then, any test that lengthens piriformis and causes increased pressure on the sciatic nerve is a test that you would conduct to determine whether the pain that an individual is explaining, sciatic pain, is sciatic pain due to compression of the piriformis or something else, like, for example, disc pathology in the low back. All right, guys, I'm going to leave it there.